Okay, so I invite Dr. Praveen Muraly to deliver his talk on unwinding the twist in macular edema.
So first I'll start with the most common thing, the bread and butter of our retina practice. So that's diabetic macular edema. So this we see in and out of our practice. So we divide into center involving, non-center involving. So the non-center involving are the one with good visual acuity. So these are the one where there are two school of thought whether to observe or whether to treat the patient. So since they have good vision and the progression over years time is less than 15%, so there is not an it's not an urgency to treat such patient. You can ask the patient for a good glycemic control, do a lipid profile. A lot of them they have hard X rates, so you can send them to a physician. And once everything is under control, maybe you can. This is one of the indication where you can do lasers, focal laser. You can either do an angiogram, see the leaking aneurysms or hit the aneurysms, or you can directly target them under direct visualization. The center involving, as such, we don't have much issue. The standard line of treatment at present is anti-VEGF. The indications of steroids are few. Some of them give in naive treatment also. But otherwise, in a vitrectomized eye, you can go ahead, or in patient with antithromboembolic phenomena within 3 months, you can go ahead with the depot preparation. And the other confusing thing is when you have PDR with 6/6 vision and non-center involving. So in this case, in case you're advising laser, there is chances that the non-center involving CME can or DME can involve the center. So here, either you can go ahead with the anti-VEGF treatment followed by laser, or if you want, you can directly go ahead with laser if patients are not willing. And then once the vision drop, maybe it's little dicey how to take a call, but then you can decide on patient-to-patient basis. When there are big vessels which are elevated, in such cases, giving anti-VEGF again is a confusing situation. So in such case, you can go ahead with lasers directly. Maybe you can keep one or two half this this diameter away from those elevated NVs, so that you prevent formation of tractional detachment. In case of asteroid halosis, may be difficult to see those NVs in the early stage, so you can do an angiogram, and in case there are NVs, you can directly go ahead with the PRP pattern. Or if there is only a CSME in such cases, then you can treat accordingly. DME in pregnancy is always tricky, dicey how to treat. Anti-VEGF as such should be avoided because of because of you can have some issues with the fetus or the developing embryos. So if it's in the last trimester, maybe you can observe for 1 or 2 months. Post-delivery, there are chances that the DME may resolve. However, during the first or second trimester, if the vision is progressively deteriorating, you can consider giving intravitreal depot of steroids. You should inform the patient about the chances of cataract and glaucoma well in advance. So just seeing the OCT, we should not come to a diagnosis and treat such patient. So when you just see this OCT, you may have, if someone refers a case or someone because of the online procedures, online diagnosis and all, online opinions taken, just seeing OCT, we should never come to a diagnosis and start treating the patient. You should have an overall view. So this was a patient with malignant hypertension. So one of the subtle feature or early signs of a malignant hypertension is CS detachment at the macula. So if you can see a detachment without a disc edema, we can consider them as malignant hypertension, and you can, even if the BP is low, this is one of the subtle signs we can recognize and send them to physician for getting the underlying BP controlled. To treat or not to treat is again a debate. I think so. Most of this patient, once you control BP, the edema resolves. However, there are a lot of other small studies, not large series, where bilaterally one eye was given intravitreal steroids or intravitreal anti-VEGF. The one with intravitreal steroids or anti-VEGF given, the contrast and the patient perception was better compared to the other eye. The other thing which can get confused are IGTs. So if you can see clinically, you can see those fuzzy, hazy margins. In little more advanced case, you can see pigments. Once you see pigments, the diagnosis is quite obvious. Our OCT in the early phase can pick out all those subtle signs, and yeah, these two are like a very classic case of IGTs. This also is for the general people may confuse, but I think so most of the retina people will identify very easily about the optic disc pits. So they have one of the causes of multi-layer schisis in, you can see schisis in all the layers. So one of the diagnosis or classic diagnosis is optic disc pit. Other thing, something like dome-shaped maculopathy, where in case you see a dome, then don't just consider this as CSR or any other thing. So you should remember such pathologies also. And drugs, there are many drugs. This is one of the most commonest one. So if you can see fine crystal, go ahead with history. If you can ask in detail, you can get the history from the patient. Same thing with inflammatory conditions also. If you just see the OCT or thing, you may have a edema, but if you see peripheral area, you can get a pars planitis or vasculitis, which can give a DD for your macular edema also. If patient had a recent surgery done, pseudophakic CME should also be kept in mind. Treatment as such, we have, you can go ahead with topical steroids or topical non-steroidal drugs. You can even consider giving PSC if they are not resolving. So the holistic approach is always required. Don't just go by OCT. So just a macular edema on OCT, but however, when you see a fundus picture, you can see a big patch just superior to the fovea. So retinitis patch investigated, came toxopositive, and was treated for the same. A few other conditions like RP can have CME-like picture. Okay. Yeah. Thank you.
Thank